today's webinar. We are here to talk about expert perspectives, digital health, and quality care. It's great to be with all of you. I am joined today by Dr. Sean Griffin, who's our president and CEO of URAC, Ann Mon Johnson, she's the executive director, chief executive officer at ATA, and Carrie Nelson, who is the chief medical officer at Amwell. Real quick, here's what's our discussion plan for today. We're going to talk about terminology in telehealth. We want to talk about what were the provider perspectives on telehealth like prior to COVID-19. So we're thinking early 2020, end of 2019. Now we're going to talk about provider satisfaction with telehealth. And then we'll talk about telehealth as a team approach to care and how telehealth can play a role in value-based care. We'll talk about the role of accreditation, and then we'll close it out with where are we going with this? With that, I'm going to stop sharing my screen. So my first question, and Carrie, I'm going to ask you to kick us off. And I'm going to ask all of the presenters to tell us a little bit, 1 to 2 sentences about their organization. And I find it, and I think you all find it more interesting to learn how these panelists actually got into telehealth as opposed to just their bio, which I'm not going to read to you. I would bore you, and I don't like boring webinars any more than the rest of you do. So Carrie, why don't you kick us off? We'll go to Ann, and then we'll go to Sean.
You bet. Happy to. Thanks, everyone, for being here, giving us a little sliver of your day. I know that's hard to give up, so appreciate you coming to the webinar. Carrie Nelson, I'm a family physician by training. I've been working in the realm of healthcare transformation for more than 20 years, leading quality, safety, and population health efforts. Most recently, I was with Advocate Aurora Health System, where we were in deep on value-based care, so I look forward to that part of our conversation. Much like others who went through this pandemic together, I started to do some soul searching around where I could be the most impactful in the next iteration of healthcare transformation. And I recognize that traditional healthcare systems where I've lived out my career need good partners, and Amwell exemplifies that for me. So Amwell, to say a little bit about Amwell, it's a telehealth platform writ large. So a lot of us think of telehealth as video visits, but it is far more than that. And we are fortunate to have a single platform that enables tele-driven care to achieve a hybrid care model for other people that are in the traditional healthcare system, such as payers, providers, and health systems, and others that don't maybe fall into that category, but very much need to be delivering healthcare to the people that they're caring for. And so that's the organization, Amwell, as in a nutshell, and myself. You're muted.
Not a webinar if I'm not muted. And why don't you take the floor?
Sure. Thank you so much for having me. And like Carrie, I'm appreciative of everybody's time today. I'm Ann Mon Johnson. I'm CEO of the American Telemedicine Association, or the ATA. I joined the organization in the beginning of 2018, and I came to it by a series of startups, all in healthcare, all using healthcare data. And the last 3 organizations focused on helping consumers navigate the healthcare system using decision support tools, digital mobile apps, because as we all know, healthcare is a very confusing and confounding industry for most of us. And today, I am now leading an organization that represents over 400 organizations, delivery systems, academic medical centers, payers, solution providers, like Amwell, like other organizations that provide just synchronous telehealth, as well as a lot of the enablers, the technology and the scaffolding, if you will. And we're all united around this vision that we're here to ensure that people get care where and when they need it, that when they do, they know it's safe, effective, and appropriate, while enabling clinicians to do more good for more people. And we came up with that vision and settled on that vision well before the pandemic, but obviously it has a lot more meaning now. It's true that we had problems with the healthcare system in the US way before the pandemic. And so we really see that telehealth is a mechanism for reimagining care and how care is delivered. So eager to get in the conversation with both Carrie and Sean.
And Ann, my guess is we have several of your members on this webinar today. So welcome to those ATA members who are here with
Thank you.
us.
And if you're not a member, you should be. So
Sean, your turn.
Thanks. And thank you for being on this, Carrie. Thanks for being on this with us. I'm Dr. Sean Griffin. I'm the president and CEO at URAC. I have been at URAC now for a little over 3 years. My background, like Carrie, I was a family physician. So I actually started off in rural family medicine in the state of Iowa and then in Missouri, and came into the technology field. I was a chief medical information officer, first in Missouri, and then I went to Baylor College of Medicine in Houston, Texas, where I was their initial chief medical information officer. I then moved over to the Memorial Hermann system, where I was very active in population health and value-based care as their chief quality and informatics officer for their ACO and their MSSP and their CIN and a bunch of other acronyms. Did that for about a decade, and then I was a consultant for a couple of years and came to URAC really hoping to influence care more broadly. I think that when you're a physician, you can touch about 6,000 people in the course of delivering care in a year. And here at URAC, we are shaping care for not just the United States, but across the world. So really to have a chance to impact care and to set standards and to be that gold star indicating that people have been independently verified that they measure up. And very proud that URAC is an independent accreditation organization that takes input from patients, providers, payers, the general public, and puts them together in standards and holds people accountable for achieving those standards. So we've been in telemedicine for almost a decade now. We're one of the largest telemedicine accreditors in the United States and now across the world. And just very happy that everybody has showed up for the telemedicine party that we were holding 10 years ago. And now people have adopted telemedicine. Very excited during the pandemic to see how telemedicine bloomed. And we're all hoping that nobody tries to stick it back in the bottle with too many regulations or too many restrictions, as we think it has a huge opportunity for delivering care in innovative ways and to more locations than it's ever been before, and more patient-centered than it's ever been before. So that's my background.
Thanks, Sean. I promised that we'd start talking about the lives of clinicians. And Carrie, I'm going to ask you to start this one first, and then Anne and Sean jump in where you see fit. We know the lives of clinicians are stressful. We know they're administratively heavy. What are some of the challenges that clinicians are currently facing? It's not just patient care, it's the whole spectrum of healthcare.
Sure. So, myself as a family physician, I saw patients till about 4 years ago in my career. And so I experienced firsthand, the challenges of trying to meet the patient care demands any given day, the challenges of adopting the electronic health record, being measured on quality measures, having to do a lot of box checking to see that those quality measures are satisfied, and then also trying to do the real work of practicing medicine, where we're actually developing a relationship with patients, we are making diagnoses, we are developing treatment plans, and it was extremely burdensome. And we saw, truly how the electronic health record, I think, was a major factor in clinician burnout. So we went into the pandemic with a pretty fried out healthcare workforce, and it only got worse from there. So I think we had many opportunities for improvement already before the pandemic struck. And my belief is that we've learned so much now as to how to be a better health system, and we just need to really take a hard right turn from the road that we're on in order to enable that in a way that will also enhance the clinician experience.
I would just add to that. I mean, Carrie, you've made a number of great points, and I would just preface the pandemic and the stress factor of clinicians that there's an inadequate workforce, clinical workforce for the population that we have. And this isn't even a problem just in the US, it's global. And so we have inadequate workforce, inadequate access. We're asking people to do more of the same way. And so that's just physically and mentally impossible. And so this is one of the reasons why we think that telehealth did so well during the pandemic, and clearly has provided a lot of benefit, not just to clinicians, but to consumers as well. So you can't expand a workforce through cloning. That's scientifically not proven yet. And so we really see the idea of using technology to reimagine how care is delivered is really an important focal point for us.
Yeah, I'll just jump in and say I think you both bring up good points. You know, the amazing thing is we had unhappy clinicians and the patients were unhappy too. So it was just working well for everybody. It's not like we were spending too much also to go along with it. I think that when you think about telemedicine and the innovation that has come up during the pandemic, if you take a good set of tools and you give it to a bunch of really smart people, you'd be amazed at the things that they can accomplish. And clinician burnout, I about a month ago I went back and I visited my old practice back in Missouri and visited one of my old partners, and we were talking about it, and he said, you know, Sean, back when you were here, which is about 15 years ago, he said those were the good old days. He said the hamster wheel has gotten faster, the check boxes have gotten to be more, and the good news is the patients are just as unhappy as they were before. And I think that when we look at things, you know, telemedicine doesn't fix everything, but not everything was broken. But there are things that it does fix that were broken, and nobody walks across the stage to pick up their diploma and is thinking, "Oh, good, I get to be a documenter the rest of my life. I get to check boxes." It's about delivering care, and telemedicine has ways that it can make it be more about delivering care. I mean, when I was a patient, nobody wants to go spend 3 hours in a waiting room. You know, we don't spend 3 hours in a waiting room now waiting for a travel agent to book our flights. So why are we doing it in medicine? I think there's just so many ways that technology is supposed to make things better. And medicine is one of the few areas where when we applied technology, we made things worse for everybody. And I think that has to do with the design and the way things were executed.
Thank you. I want to make sure that we use the terminology. So we've shifted terminology, and Anne, I'm going to ask you to talk about this, but the language we use to describe virtual care has shifted over the past few years. First it was telemedicine, and then we said it's more about the health and it's telehealth. And now we're using terms like virtual care and digital health delivery. And I know you even said to me, introduce ATA as ATA. Let's talk about what does that mean? What does this imply for how the practice of virtual care, digital health delivery is shifting?
So I've heard it described a number of different ways. There's telehealth, there's telemedicine, digital health, digitally enabled care, virtual care, virtual first. All of these are referring to the ability to use technology to facilitate a communication between a provider and a patient, or a provider and another provider. And I think Carrie's point earlier is really important, which is it's not just a video, right? It is asynchronous, it's synchronous, it's remote monitoring. It's the ability to stay connected in a way that we haven't been able to before. I think the other point is that, at least within the construct of the ATA, we define it quite broadly. We have a number of organizations that are in remote monitoring, like Validic and BioIntelliSense. And these organizations, underneath the hood, a lot of AI is going on. And so AI is an enabler for technology, and for technology delivered care is part and parcel of what we consider telehealth. I think it's also important to know that if it's confusing for us, it's confusing for everybody else. And so one of the big benefits that came out of the pandemic is that telehealth became a household word. And people, when I joined the ATA and said I was going to be doing this, people were like, telemedicine, is that when you talk on a screen to somebody? And now they understand that it's much, much more than that. It's the text messages that they got to say, okay, tell us about your symptoms so we can tell you whether or not you should go to the ER, or you can stay home and just monitor your symptoms. So these are, you know, the whole idea of being confused about this. It's just important to remember that if we're going to create a way for people to get behind this whole idea of enabling clinicians and consumers to continue to connect, then we have to make sure that certain legislation is promoted and waivers are kept in place, both at the federal and the state level. So call it what you want, but don't confuse people in the process.
Absolutely. I actually just asked the audience 2 questions, and I hope they'll respond in the chat. First is, what terms are they using? And Jasmine Davis says she's using virtual health / virtual care. And second, I'm sort of curious who's out there. What technologies are they using? You mentioned texting. Today I got a text and an email from a provider, video, remote patient monitoring. Maura saying one of the issues, and anybody in national organization, we see this, is the definitions that all the states have their own different definitions.
Mhm. Yeah, and just getting to the back to the point about burnout, really it's technology enabled care, and that includes AI and automation, which might not even fit into some of those categories around virtual, because it's also the ability to get doctors out of the box checking world, because I think that there's a lot of intelligence we can build into our systems that certainly need the human interface to be able to make sure that, you know, we're on track with the best care, but that we can free really important cognitive power up for more complex medical management versus this person who's over 50 needs a mammogram. I mean, to me, that doesn't require a physician to be able to make that assessment, but technology can certainly enable that. Now, now the physician may need to validate that that's, you know, that they may need something a little more complex than a regular mammogram, but at the same time, you know, we can close a lot of care gaps by just automating a lot of these things and taking
And
it
really
off their plate.
extend people in the process, right, Carrie? I mean, the whole
exactly.
idea of allowing clinicians to practice at the top of their license. I didn't understand that concept before. I understand it and embrace it wholeheartedly now, because it's not just telehealth. It's not just in-person care. It's a hybrid model. And so I think that at least is what we are advancing within the ATA, this notion that, you know, you view telehealth as a modality of care that is at the discretion of the physician and the clinician to use as they see appropriate.
Yeah, I think that moves us into some of the things about team-based care and that type of work. I mean, you know, when I was practicing, one of the most important decisions that I ever made was who was going to be my office nurse, and that's back in my family practice office. And I had an experienced nurse who helped this young doctor, and it made me better as a provider. And we want to make sure that the tools that we're giving to people as they practice make them better. They help them to do more, and we aren't hamstringing them with slow bad things. Telemedicine, when I was practicing, telemedicine for me was a stack of notes that were sitting on my desk when I came out of the exam room. And I would look at them and be like, do I know this person? What are they asking about? Do I need to see them? And it's the same thing today. You know, when is a telemedicine visit appropriate? Are we talking about behavioral health counseling, where telemedicine may be even more effective than some in-person things, because you can see the world around them, and there's a convenience aspect and those sort of things? I'm not quite at the place where I'm advocating, telemedicine for heart transplants or anything like that, but there's a whole bunch between, you know, what's a phone call and what's a heart transplant, that we need to think about how we can be using tools, including telemedicine, telehealth, virtual care, remote patient monitoring, add your buzzword bingo phrase in there, to make it better. And how can we have the right people doing the right work? When it comes to physicians, I say, you know, like you wouldn't use a physician to check a box on a mammogram, you don't use your iPhone to drive a nail. Now, technically, you could make it do it, but that doesn't mean it's the best tool for the job. And we need to think about how our tools fit with the work that needs to be done.
Well said.
We are getting fantastic comments in here. Let me jump to where we were. I kind of want to go into the behavioral health, but I also want to stick to what we had planned. But I don't want to not talk about behavioral health. So let me put that in here and let's chime in there. Sean, you and I have this conversation all the time. But let's talk about it from the provider perspective. And I realize I'm throwing you a curveball, something off the agenda. What does it do when you have that provider relationship for telehealth, for behavioral health and mental health care?
Well, are you talking to me? Because I can't tell who your eyes are at on the screen here.
Sorry, Sean, my eyes are on you.
Okay. So as a family physician, I believe in a fundamental richness to the patient provider relationship. That's the basis of being a family medicine doctor. Is you know your patients. It's not transactional. It's more relationship based. And whether you're a family physician or whether you're a psychiatrist or whatever your role is, knowing the person helps you to understand changes that happen. And I got to know my patients very well. There were great examples, and this is not behavioral health, but it's related to it. I had some older patients who honestly, the holidays when their relatives would come to town and see them after not seeing them for 6 months, invariably they would get packed up and brought to the emergency room. And if the emergency room doctor didn't know the patient, they would stick that patient in the hospital. Now, the fact is that patient wasn't any worse on Thanksgiving Day than they were a week before Thanksgiving, but because the relatives hadn't seen them in a while, because the doctor didn't know them, they thought things had changed. I could go into the ER, look at that patient and say, this is the same as they were last week. There's no need to put them in the hospital. That's the fundamental knowing your patients. It's being able to understand the subtleties of language, the changes in behavior that are meaningful versus that what somebody else might miss. I've compared it before. The primary care relationship to a patient is like dancing. You do better with your own partner, and having your provider know you and know about you and know your life and know your values cuts through 40% of the getting to know you part of a medical relationship. And it works in behavioral health. I mean, I'm all for continuity of care. There are some things that are meant to be a transaction. Okay, splinter in my finger. I don't care who the doctor is. Get the splinter out of my finger. But when I'm concerned that my uncle died of heart disease and all of a sudden I've got some tightness in my chest, it really helps to know me so that you're not just answering the question of the moment, but you're understanding the implications of it. And I think that goes in telemedicine. And that's why our standards emphasize continuity of care and sharing of information and all those sort of things, because you're not just, Thursday at 1 o'clock when you come into the office.
Yeah, I couldn't agree more. I mean, when I was in my training and also as a residency program director, I did home visits with patients, and I'll never forget some of those home visits and all I learned about them and their family and the relationship that got even closer through that experience. There was so much gratitude on their behalf, and then I just really sort of stepped into their family there for a period of time. What I hear from our telemedicine providers is that it's as close to a home visit as they've had in many, many years. And so that alone allows you to really see into the lives of patients. That can also, getting back to the behavioral health point you're making, Lisa, can help you uncover issues there that may not be as visible. People can put a good face on to come to the doctor office for, an hour a week. And so as it relates to behavioral health, I will say that's something that we've been able to sustain very nicely post-pandemic, and it's been a game changer both for patients and clinicians. The clinicians, many times I've talked to those that felt, I might have to leave my practice because I've got a family now. And if they can engage in a telemedicine solution, they can actually have more life balance for themselves. They've also expressed to me that there's times when they've been in their office and some of their office staff is quite lean, and they may even be alone in the office with a patient in the evening, and that patient may not be doing well, and it can become an upsetting and frightening situation. They don't have to deal with that at all in the case of telemedicine. They can get help for people if they need it, but there's no real risk to their own health by being alone in that kind of scenario that's oftentimes does exist in a regular behavioral health practice. So
Carrie, you reminded me. I always remember in my training, I did a psych rotation. I always remember stay between your patient and the door is something that they teach you during a psych. They don't wear a tie and stay between your patient and the door. And in a telemedicine visit, you're always
not a concern. You can actually
safe.
attend to caring for the patient versus attending for your own safety, right? And so that there's just so many wins in the behavioral health realm. The other thing I'll call out is that we have a digital solution for behavioral health called SilverCloud that is a great way. It's evidence-based and it's a texting methodology where people will interact with this program in a way that truly does mitigate their depression and anxiety. And we can also then escalate them to in-person or, face-to-face care through telemedicine if needed. It actually shows that some people are more inclined to do the texting-based CBT kind of approach than they would be even interacting directly with a behavioral health provider. So a lot to be said for behavioral health in all of this.
Yeah, I would just add, that there are actually studies that have been done. Peter Yella-Lees, who's a physician, a psychiatrist, and a leading proponent of telehealth, talks about both clinician satisfaction as well as consumer satisfaction with virtual or telemental health visits. And there was a question that popped up in the chat about audio only, and we're big proponents of audio only. And that's because if you think about it, many of us have the ability to use a smartphone and others do not. And so why would we discriminate in that fashion from people who cannot use a smartphone? So I think that, it's really important to keep that in mind. As for the study, I will get that to Lisa and to the folks at URAC so that they can make that available to you.
And just in follow up what you said, I train in rural family medicine. I was on the National Quality Forum's rural telemedicine and emergency services panel, and my mother-in-law lives in a part of the country that doesn't have cell service, let alone broadband. And so understanding that there are things that can be handled with just a phone, and there's things that can't, and how in medicine in rural areas learns to make do with what they have, and just because you're in an urban area, you still might be underserved. There may not be doctors' doors on your street or those sort of things. So I think we need to understand that the world is not just the 50 largest metro areas. Not everything is a quaternary medical trauma center or anything like that, and we have to allow that. Sometimes the situation has to be adjusted to fit what you're dealing with, and I think that telemedicine helps us to do that sometimes.
And I wouldn't forget the urban scenario in what you just described. So we know we have 14 million homes in urban communities that do not have broadband access, and 75% of those homes are people of color. And it can take you 2 hours to get from the south side of Chicago to the north side of Chicago, where you might need to see your super specialist, and you may not have transportation. So there are many reasons. And then I'll just throw in my father, who doesn't own a smartphone, wouldn't know the first thing about how to talk to someone telemedicine, but he'll talk to you on the phone all day long. So I just think there are so many scenarios. We've really got to be able to customize solutions for people. Otherwise, we're just creating a new disparity.
So,
exactly. If I could, just to point out the connectivity issue, we have formed an advisory group on using telehealth to eliminate disparities. And this group put out their first work product was a framework that looks at the different issues associated with reaching underserved communities, rural as well as urban. And what they found and what they posited was that while connectivity was at the tip of the iceberg, there are a lot of other issues. And the reason why they purposely put connectivity at the top is because there's a lot of discussion about that, and broadband and internet. And what we wanted to emphasize was that even if you address that, even if you somehow magically arrange for everyone to have access, the idea that somehow everybody would get access to care, it doesn't happen that way. There's so many other issues in terms of affordability of the data plan, which is something that the VA has addressed, in terms of things like digital and health literacy, trust, fundamental trust. So just want to underscore how, yes, connectivity is important, and it's really important to figure out a lot of different ways to get to consumers.
I love what Diane Lynn said here. She said for specialty deserts, audio only is often the difference between care and no care. With that, I want to transition us a little, because we could spend between mental and behavioral health and social determinants and access to care. I'm going to ask Laura Wood to chat in both a webinar that we had on access to care, and she already chatted in the white paper. I was about to ask her to do that. So we have those there. You can read about what some of the organizations are doing related to both of those. But let's talk about provider satisfaction with telehealth. And Carrie and Sean, you already started this a little bit on safety. Carrie, why don't you take the lead on this one?
Sure. So, I'm a bit perplexed about the provider satisfaction issue, because I've seen in my own experience, working through the pandemic, and providers that were staunchly against using telemedicine suddenly being forced into it and realizing this could actually be a very positive change for them in terms of their level of burnout. Telemedicine is more efficient both for the provider and for the patient. And so I've got those stories. At the same time, we've got the trend that we've seen where people have kind of gone back to normal. And I was just talking with a colleague from Intermountain who has a very robust telehealth program, and they're finding that they're having trouble getting them unstuck from going back to the old way of doing things. I just think that we've got a window of opportunity here that we've got to seize upon, and it's going to be on us as clinicians and leaders to help get that movement going. So I do believe the potential is real, but the reality is that the experience that physicians have had with technology is largely the electronic health record. And that was a big change that just has not improved their life. I do believe this is a change that can improve physicians' life, improve patients' lives and health outcomes, as well as decreasing the cost of care. And I can say I believe that, but the reality is it's not just me that believes that. It is actually shown to be true in studies and in the literature. So I'm struggling with the challenges that we're seeing where clinicians are kind of going back to the old way. I feel like it's a set of cognitive biases that are based in fear, and that fear is really got to be overcome.
So several things just to pile on here. I was an old CMIO. I saw the promise of electronic medical records and all of the data and all the good things. And then I discovered that very often the implementations were being driven by the finance department deciding which boxes needed to be checked and which things they could force into the physician workflow. And that's one of the things that led to burnout. The providers before the pandemic were suffering from some burnout, and there were all sorts of studies going on about that. The EHR was a contributor. Also, the ever increasing, quality measures that seemed meaningless, and the hamster wheel and the 7-minute visit, and nobody goes into medicine to see people for 4 minutes and that sort of stuff. And I think that when I look at providers now, the ones who had a meaningful, thoughtful implementation of a well-designed system for doing telemedicine. And the biggest issue that we have is very often with providers, we say, and you need to do this, and you need to do this, and we just keep piling it on. And burnout comes from too many things being piled on and nothing ever being taken away. And part of my sort of theory about this is that for a lot of people who are doing traditional office-based medicine, that in some ways the old hospitalist model sort of comes to mind, is that you need actually probably some dedicated time where you're doing virtual visits. Is one model that seems to be a little less disruptive to some practices. I know some people will do, okay, I do office visits for an hour and then I do telemedicine visits and those sort of things. But the office-based design was very physician-centered in the way that it executed. It was the people get lined up in the waiting room and they get stuck in rooms, and I see them as I work through them. And I'm sorry about your 45-minute wait, Mrs. Johnson, and all of those. Sorry about picking Johnson there, Anne. That was just a name out of a hat.
Okay.
But during the pandemic, when everything was crazy, some of this is just I'd like to get back to normal. And for a lot of providers, their normal is that old way. And if you take 100 physicians and you throw all of them into this new innovative thing, you're going to take a bunch of them who think this is fantastic. They come at it with an open mind and they do great and they don't want to go back. You're going to have a bunch who kind of go, I miss the good old days, whatever those good old days were, and they forget about the bad parts of the good old days. And I think we need to understand that some of this is the uncertainty with the federal regulators, the state regulations, the payment models, all those sort of things, to where you're giving providers and systems excuses for why they won't adopt a new way of doing things because there's too much uncertainty about it. When is the public health emergency going to end? How does my contract pay me for this? All those sort of things. And so it feels safer to go back to the old ways. But we do have a whole new crop of champions who have shown how this can be better, how this can be different, how this can be an improvement. And you kind of have to give them the pulpit and let them speak for a while and share their experiences. And that's one of the reasons why the ATA is so important. The ATA is a wonderful place for the enthusiasts to get together and to get the stories together about how this is successful and good and wonderful. And not just from the clinician standpoint, but from the how can it save money? How can it improve quality of care? How can you address social determinants, and bring all that together so that Anne can say what the research shows and those sort of things, and we have those wins. And I think that's incredibly important with going forward, that we let this fix the things that it can fix, and we support it so that it can fix the things we dream of it fixing.
Well,
that's a great, I'm sorry.
Oh, go ahead. No, go ahead.
Do you mind if you prompted a thought there, Sean. I think during the pandemic, we took in-person care and we moved it online. If that's the only thing we ever do, we will have fallen far short of what's possible. We need all the bells and whistles. We need team-based care to be enabled. We need remote monitoring and digital and automation. All of those things are what the game changer really is. It's not just taking the visit and moving it online. And
Completely
that's what
agree.
physicians haven't seen yet.
Yeah, the expression we use is, if all we do is use telehealth to replace the face-to-face visit, we'll have sold the whole thing short. You have to use it. You have to go back to what the problem is. inadequate workforce, insufficient. They're more than adequate if there were more of them, but they're insufficient. So huge wait times to get in. People, you take mental health, 1 out of 5 Americans pre-pandemic had a mental health issue. And yet many counties in the US have no mental health resources. So you have to use this to enable care. I would say the one thing, Sean, that I would change about our approach is we want an honest examination of what's working and what's not working, because we're enthusiastic, but we're not blindly enthusiastic. And I know you didn't mean it that way at all, but I want our audience to know that. Because again, we have coming in September, Telehealth Awareness Week, which is September 18 through 24. And what we're doing during that time is we have, several dozen endorsing partners, which are patient-facing organizations like the National Organization for Rare Diseases. And these are organizations who are carrying the message of why telehealth is important to patients. And it's important to bring it out there from a physician's perspective. So the Awareness Week is really to highlight what's worked, what do we have to work on as a entity and as a community writ large.
So a couple things, and I think you're enthusiastic about telemedicine as an organization because you have looked at all parts of it. I don't think you're blindly enthusiastic about telemedicine because there are places where it fits great and other. I mean, I want to say I think you're a great organization. I think you're one of my first meetings I had after I came to UREC because I saw the excitement of telemedicine, and we've gone from where it was as how do you get the technology connected to how you actually change care when you have it. The thing that Carrie said sort of reminds me. It's like if we stopped the internet when the dancing baby video, that computerized dancing baby, if we'd have stopped the internet then, do we want to stop telemedicine now? I think there's so much more that it can be, and we don't want to stop now.
No, I completely agree.
So let's talk about, Lisa made this really good point in the comments about talking about how to confront the challenge that providers share that telehealth is more than in person. I'd like to talk about it as it relates to value-based care and a team approach to care. I mean, one of the things it was very frustrating yesterday. My mother was in one medical situation. They're like, well, we can't do a telehealth visit with your other provider there. And I was like, what is this not making sense here? Why can't we do it from one facility to another? How does telehealth how should it actually support a team approach to care and to that value-based care model? Sean, why don't you start?
Okay. So, I used to be a chief quality and informatics officer for a large medical group in Houston, Texas, and we had 500,000 contracted lives, and we were in a fee for service model until we actually had some value-based care contracts that said, deliver the care that you need to, and it's not fee for service anymore. When you take the fee for service sort of, turning the wheel aspect of delivering medical care, telemedicine makes a lot of sense. It makes sense for the providers. It's more efficient. You have the chance to do more things in a shorter period of time. If it was paid the same as an in-person visit, we'd be doing tons of it. But the question is, it wasn't being paid. But if you have risk-based contracts and value-based care, you're better at matching the team member to the work that needs to be done and saving the providers for the things that require providers. It's more efficient from a time span. There's a reason why concierge medical practices tend to do telemedicine visits. It's because it's much more convenient for the patient. It's more customer centered. And then when you get into wearables and remote patient monitoring, there's tons of things that you can be doing in a very efficient manner to enable care and elevate the care. And so, Carrie has a ton of experience about this, and I want to turn it over to her. But value-based care, when you take off the ticking of the taxi fare and you think about what's best for the patient and what's best for the providers and what's most cost effective, it jumps in its value for everybody involved in the chain.
Yeah, Sean, you and I both were living that same life for a number of years there. And, first off, telemedicine has value both in a value-based arrangement, but also it has many values and many positive impacts outside of that. Yeah. In the value-based arrangement, however, you don't have to worry necessarily about reimbursement. to be honest with you. You do what's right. And in fact, if it's more efficient, that's even better. The other thing is to be able to bring different team members to the table. So when I was building out our care management program at Advocate Aurora, we hired, a couple hundred care managers, which was certainly not enough to manage all the lives that we had in value-based arrangements in every practice. So we had to basically identify those practices that had the highest number of value-based lives and put a care manager there. Everybody else got something telephonic, which, really kind of interfered with the relationship development. It was sort of out of sight, out of mind. There were things like that that just didn't get as much traction as the in-person, but we can overcome those things by having a care manager, a social worker, a pharmacist, be able to telemedicine in with the physician, with the patient at the practice in a way that creates more intimacy for the whole team. And also it helps relieve the physician of some of the stuff that we're faced with, just some of the social determinants, things that we don't necessarily have the training or the time to try and work with patients on, but that a good care manager does, or a social worker. Pharmacists are great at medication dose titration. They're also great at, medication therapy management and being able to, make a very complex medication regimen less complex. Those are the kinds of things that we really should be working within a team to achieve. And we can bring that team to every location, unlike what we had been doing years ago without the broad spread adoption of telemedicine. But I do want to get back to Lisa's point before I turn it over to others about providers saying telehealth is more work than in-person face-to-face visits. We've got to listen really hard to our providers and understand what's at the root of that statement, because I think the problem with electronic health records, and I'm sorry, Sean, I may be insulting you in your past role, but I think we didn't do enough of that. There was a mandate, there was all this funding that came through and we had to get it done. And in fact, we landed with something that didn't have sufficient physician and clinician input to be able to make it more user-friendly and enhance the care model versus the burden that we find that it is. We can do better. We've got lessons learned from that experience that we can translate over into what we're trying to achieve with telehealth.
Yeah, meaningful use was the worst name in history, by the way. And
Yes.
it was a financially driven implementation and imposition of poor tools in most manners. And I implemented most of the major names out there. And they were very often became the moment where you got the doctors to do something that you've been wanting them to do for 20 years and they never wanted to. So we're going to force it into their workflow and make them really unhappy.
Mm-hmm.
Yeah, I think what we've learned in that process is that if you embed it in the workflow, it has a much greater chance of success as opposed to just plopping it in. So I think the other thing, though, about team-based care, again, going back to what might be available to people, is think about remote monitoring and sensors and how those can be used, for example, even in a patient's room in a hospital, so that the nurse or whoever it is doesn't have to go in immediately. They can interact with the patient. I mean, these are the kind of ways that people are thinking very creatively about how technology can be used to enable clinicians, all of them, to practice at the top of their license, as opposed to some of the more mundane tasks that are absolutely essential, but can be replaced or leveraged using other tools and devices.
That the remote patient monitoring, and as I see, companies on the daily are coming out with the new, what can I wear around my wrist that will tell me this? What do I need to know? What kind of data can I get? How does that, I'm not going to go into this now because we know it helps. We know it helps when the providers can get that data daily, and the provider, I'm not saying the provider has to be a doctor. That provider could be a nurse who's monitoring somebody's blood pressure or glucose levels, just to say, hey, wait, we're hitting this point. We need to check it in without having to do a daily visit. So I want to talk about the role of accreditation. And Carrie Amwell, you are accredited. We worked together at URAC for a couple of years. You were one of the earliest organizations to earn URAC's telehealth accreditation. Let's talk about how accreditation improves patient care and clinician confidence with telehealth. And what are some of the systems that accreditation makes an organization put into place to ensure safe, secure, and most importantly, high quality care?
Yes. So I just have to probably, throw a little jab at you and just admit that none of us really likes the whole accreditation idea.
Mhm.
It's not something it's something we're subject to in healthcare in a broad spread fashion, but frankly, not everywhere.
Mhm.
And when it is not present, I have seen the 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 cutting of corners to where maybe the refrigerator temperature doesn't get checked, and things like that just if you don't have the staff for it and you don't have an accreditation body asking you and making sure that you're doing it, it's easy to say we're just going to skip that today, where in fact I think so. That's just a small example of where I think accreditation has an important role in healthcare. And I will say that that I'm very grateful that we are an accredited organization. It provides a level of security for our consumers and for the health systems that we're working with, that we really are willing to put our programs, our processes, our training programs, quality measures, all of those things in front of a third party to get the seal of approval. I think if we weren't willing to do that, I'd have serious questions about, what we were hiding, And so that's one aspect of it. I also think that we're early in this game, and there's so much more to be learned. And working with an organization like URAC is a great way to bring the whole community together, along with the American Telehealth ATA, to bring the whole community together to say, what are we learning? What do we need to build out further in order to make sure that we're providing the best quality outcomes and we're really living up to the dream that we're here to try and achieve? I think it's a necessary thing, and also a really value added thing to be accredited. And I look forward to just years and years of continued growth of what we can achieve and what we can identify as important standards for good quality care and health outcomes.
Well, I just want to say amen. Thank you very much, Carrie. I truly appreciate that. One of the things that we have seen, I mean, we work with hundreds of organizations, and we've been doing this for over 30 years. We're an independent third-party verifier of quality, and I talk about how regulation sets a bar for safety and accreditation sets the bar for quality. When we update our standards, and we're on over our third version of standards now, we brought together experts from across the industry, and we brought together payers, we brought together academic medical centers, we brought together children's hospitals, we brought the ATA was at the table, federal government was there, a number of different provider groups were there also. And it's really sort of learning from best practices. When we talk in medicine about best practices and evidence-based medicine, the framework that we have for our accreditation, and you can go look at our standards at a glance out on the URAC website and see sort of what makes up our standards. We put them out there because they're not meant to be a secret as to what quality looks like. And underneath each of those standards is what we look at to verify that an organization is following those standards. And we've had a number of organizations who came back to us, and particularly around the pandemic, and they said that going through the URAC accreditation helped us to be prepared for when the pandemic hit. And we faced all of these new onboarding providers and all these new things that we had to deal with. And URAC was asking the questions 2 years ago that helped us get ready for the pandemic before any of us knew it was coming. And accreditation is really sort of meant to get you into shape before you need to be in shape. And then it also acts as sort of that endorsement that what they're doing is the right thing, and doing it in the right way to where we trust our family members with it. So we think accreditation has value. We also think that there's more than one choice in accreditation, and that's okay. We're willing to compete against anybody doing accreditations, and you should have a choice because nobody should have a monopoly in healthcare.
I would just add that one thing that we've started having some experience with is the release of a digital health assessment framework. And that's because there are literally hundreds of digital health apps out there. And the challenge is that you often don't know how credible those apps are. And so in working with the American College of Physicians and an organization named ORCA that's based in the UK that has a framework that they've deployed in Europe and elsewhere, starting to examine what makes that framework work in the US. What are the considerations in terms of privacy and security and clinical quality and so forth? And it's been a very, very illuminating experience, in part because you have employers, for example, purchasing lots of point solutions or licensing lots of point solutions for their employees and not knowing how frequently it's been updated, if it's any good. And so this gives an opportunity like accreditation for organizations to put their apps through that as well.
I did want to say, we don't go into the technical details on any of our
Right.
programs. And that's because very often the FDA sets certain standards and those
Mhm.
sort of things around what qualifies and what doesn't qualify. And what we say is, you have to comply with all regulations and all those sort of things. So we don't tell you what a good EMR is. We just say you need to be using a good EMR, and then we look at how you use it. And it's not URAC's skill set to go into the technical details. And that's why we love to work with organizations that are bringing the technical people to the table and all those sort
Right.
of things to work out those details. And we're very supportive of that. We see that as a little bit of, there's the technical details, and URAC looks at the whole program.
Mhm.
And that's really sort of a difference in accreditation. I had somebody say, what's the
Yeah.
difference between accreditation and certification? I said, for us, certification is about the person, accreditation is about the overall program.
Program. Right.
So
Right.
I want to be conscious of our time, but I also know you all have great thoughts. We could keep going at this for a couple of hours. It'd be a fantastic panel conversation at some point, at a conference, ideally. So in your dream world, and Anne, I'm going to start with you. We'll turn it over to Carrie and then to Sean. What conversation are we having? What does this conversation look like in 5 years?
In 5 years, the conversation is going to be that telehealth is health, that it's a
Mm.
modality of care, that it's not judged by different standards than face-to-face care, that it's used to extend the clinician's capabilities. It's used to meet consumers where they are in their care journey, their health journey, no matter what. And I am a pathologically optimistic person. I believe that that's going to happen because both consumers and clinicians have tasted the forbidden fruit and there's no going back.
Well said, Anne. Thank you. That's inspiring. And yeah, in 5 years, I would like to be able to achieve everything that Anne just said, and the best health outcomes, the kind of health outcomes our country's never seen before, at a reduced cost, and with a vibrant healthcare workforce that has engaged with these tools and in patient care in ways that achieves all of those things in one fell swoop.
I'm going to go really sort of simple and a little strange on this one. I'm going to say that we talk about the time before telemedicine as we talk about the time of travel agents. And we go, they worked at the time, but now things are different, and we've learned how to do it better and how to enable consumers in a much different way. I think that it can help us if we do it the right way. It can burden us if we do it the wrong way. We need the government to be supportive of it, both in regulations and in payment policies, so that it makes sense. That we can do something better for consumers in a way that we haven't done in healthcare in a long time. And I hope that it becomes a daily part of life.
Anne, Carrie, and Sean, thank you so much. This has been a fantastic webinar.